Assalamualaikum viewers. Today we will be talking about drugs affecting biliary tract and gallbladder. And this hepatobiliary tract is very important, especially as liver is the largest gland and it contributes to majority of the disease or ailments which sometimes requires emergency treatment. So these are our objectives, and our first objective is to list the drugs used for the treatment of biliary disorders and then describe the pharmacology. So for listing the drugs for using the biliary disorders, let me understand the biliary tract, hepatobiliary tract. This is the biliary system, and you can see the liver is here, there is a gallbladder, and hepatobiliary tract. You can see the pancreas here, and so it's a system of ducts, organs, and associated structures, and that function to produce, store, secrete, and transport the bile. Remember, and bile emulsifies fats. So in order to, in certain cases, if there is an obstruction of you can say this particular region, this common bile duct, due to some lithiasis, I mean stone formations, and you give some fat-rich diet, so that will trigger the release of this bile. And if the way is, if it is closed here, the stone formation is there in the common bile duct, and then it can be dangerous. So it will be clear as we proceed. As we discussed, bile is a dilute salt solution containing bile acids, phospholated lecithin, cholesterol. And very pertinent and important thing is that bile acid and lecithin form mixed micelles that dissolves cholesterol. So the derivative, or in certain cases, some acids like bile acids, like cholic acid, deoxycholic acid, deoxycholic acids, they are used as drugs, because if there is a micelle like stone formation, mean that is embedded with cholesterol is there. So if you take these acids, so they will dissolve, because they will release the cholesterol from this already made micelle coupled cholesterol stone. So these acids are also used to dissolve the cholesterol salts, and then you can manage your patient without going for surgery. In certain cases, if it is treated with the cholelithiasis or stone formation, and which is cholesterol rich, what you can say stone. Nevertheless, that's a separate story. So bile acids are necessary for normal intestinal absorption of dietary fat, as we referred to earlier, and these cholelithiasis may be there from the formation of gallstones, which include cholesterol pigment, and those acids, as I discussed earlier, can be helpful in the dissolution of that particular cholesterol-rich stone. If calcium is being deposited inside these stones, then it can be dangerous, and that will be very difficult to dissolve that stone through the pharmacological treatment, and then the drug therapy is required. This is a classical gallbladder, and there's a classical stones are there, you can see it, and these are gallstones, and this is the cystic duct, and if the stone is here in the common bile duct, in this terminal region that goes, and then it can be dangerous, because so on abdominal ultrasound, and in the ultrasound you will see that the common bile duct CBD is dilated here. Why? Because of obstruction. So if CBD is dilated, so in the ultrasound report mean that obstruction may be there at the level of there is no way to say that the bile that can be secreted go into the hepatopancreatic duct, which is the small intestine. So important thing, this is the diagram, and if stone formation is here, it is in the cystic duct, it may be here in the common bile duct, and then it can be dangerous. And if it goes here, and then the care should be taken that pancreas, involvement of pancreas is if there, then it is a very alarming and emergency situation that can create problem for you, because that is one of the vital organs. So, what is the concept map? There is inflammation is there. You see, let me go ahead for that. And once inflammation is there, there will be pain. You see, and there will be pain due to the spasm. Pain due to the spasm. You see, pain due to the spasm of this particular uh, uh, smooth muscles, and there may be MSs may be there, MSs may be there. You see, MSs may be there, nauseating effect may be there, and you see, pain is there. And what you have to do now, there may be bacterial infection may be there. You see, and in order to treat this, so for this you will give anti-inflammatory drugs, you may give analgesics drugs, analgesics. You see, so analgesics you can give anti-inflammatory, you see, inflammatory drugs, and for the spasm you will give antispasmodic drug, you will give antispasmodic drugs, and for the MSs you will give anti-emetic drugs, and you see if acute infection is there, you will give them antibiotics like ciprofloxacin or third generation cephalosporin, and you see, and there may be you will give metronidazole as well, metronidazole, azoles or metronidazole to cover the anaerobes. You see, so these constitute the different classes of drugs that may be helpful in the management of acute acute either cholangitis or cholecystitis. You see, no matter the nature of the cholecystitis is, whether that is acalculous cholecystitis or calculous cholecystitis, or as the case is. So these are the drugs that are to be used, classes of drugs that are to be used in the management of cholangitis or cholecystitis. Now let me proceed. So this is the concept map. As you see, for stone formation may be there, and this stone formation may be due to the cholelithiasis. You see, cholestasis means that the stasis of the bile that is there, and that then there's stone formation may be there, or sludge formation may be there. So this is usually associated with parental nutrition, especially when you're taking on total parental nutrition, and you see, then you may come across with cholestasis or cholestatic jaundice. Then sludge may be there, and antibiotic related pseudo lithiasis may also be there, like ciprofloxacin, because when obstruction is there and that the level of the ciprofloxacin it is high, so it crosses the limit of the precipitation. You see, and once it precipitates, so then sludge formation is there. There may be inflammation, as I refer to, and for inflammation you will give anti-inflammatory drugs, and the drugs that is going to dissolve the cholesterol, base cholesterol-rich stone or cholelithiasis. So you will give the bile acids, and that bile acid therapy includes the chenodeoxycholic acids and the ursodeoxycholic acids. In case of infection, that may be acute cholangitis or acute cholecystitis or chronic. And the chronic, remember, chronic doesn't need antibiotics and supportive therapy. You see, it as and when required. For the spasm, you will go for the antispasmodic, and you will take support of analgesic as we discussed it in the previous slide. Now, going to the bile acid therapy for the gallstones. So there will be chenodeoxycholic acid, as you can use the acid therapy. And in this particular case, this chenodeoxycholic acids decreases the hepatic cholesterol synthesis and secretion. You see of this the cholesterol content of the bile. You see that is decreased, and cholesterol passes slowly from the stone to the bile. But remember, it dissolves the stones, and the bile acid pool and the phospholipid output is increased. The most dangerous side effect is the hepatotoxicity, because it can be due to the damage of the hepatocytes, and of course you can go ahead for other class of bile acid therapy as well, that is ursodeoxycholic acid with name in the market available ursodiol. But remember, again, it is absorbed orally. It can be given orally and conjugated in the liver with glycerin and taurine and excreted in bile as well. So care should be taken if there is that the enterohepatic circulation is not totally obstructed, Had it been totally obstructed, then it can be dangerous as well, because the lithocholic acids is hepatotoxic, as similarly to the other derivative of this bile acids as well. So the serum half-life is approximately 100 hours, and it can be increased in the enterohepatic circulation. Enterohepatic circulation mean that circulation that between the intron and the blood, and you see passing through the hepatic portal system. The the mechanism of action of this ursodeoxycholic acid is that decreasing the hepatic production of the cholesterol. You see, remember, cholesterol is synthesized at a higher rate, especially it is in the night. And you see, you can give statins as well, but statin can create its own problem because they're decreasing the atonia of 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 the bladder as well, and it's also in higher doses associated with the lithiasis or stasis, you see, and can promote the stone formation. So you can go ahead for any other anti-hyperlipidemic drugs in case of hyperlipidemia associated with cholesterol rich stones. This is a separate story because we have to focus on the drugs affecting the biliary tract. And here, dear students, you see, the hepatocytes has to be stabilized by two mechanisms: decreasing the concentration of endogenous bile acids and decreasing the immune-mediated hepatocyte destruction. So this is relatively what you can say safe as compared to the previous salt or molecule. The therapeutic uses of this ursodeoxycholic acid is dissolution of for the resolution of the small cholesterol gallstones, and then prevention of the gallstone in obese and hyperlipidemic patient, and the cholestasis associated with total parenteral nutrition, and the primary biliary cirrhosis, especially that reduce the liver reduce the liver function abnormality and improve the liver histology by stabilizing the hepatocytes, and probably by this mechanism, you see. And thus this class of drugs these bile acids are very good. These are the doses, and the adverse effects you see is hepatotoxicity as a class for the cholic acids, but relatively this ursodeoxycholic acid is safe. There may be biliary sludging as well. This is another condition that biliary or pseudolithiasis is the formation of a fine granular precipitates, and that granular precipitate that usually called as sludge, which differ in composition than the ultrasound picture from true gallstones. Remember, it is not rounded shape, and it can be very irritating, and it can create very nauseating effect and excessive spasm as well. So the causes may be excuse me, causes may be gallbladder hypomotility and recent surgery, and drug induced as antibiotic associated biliary pseudolithiasis as seen with ciprofloxacin. Ciprofloxacin is a drug that is notorious for drug induced pseudolithiasis. So what to do? Antibiotic assessment associated biliary pseudolithiasis. In this particular case, if your patient is taking ciprofloxacin, so just stop it, and this usually happen at the start of the therapy following 3 or 4 days. So you are treating patient with for one problem and creating the other problem. This can be dangerous as well. So you should be quite vigilant about this when you are going to use ciprofloxacin. Especially this is in elderly and those where the patient is having a prehistory of cholelithiasis or gallstones are there. Then the antibiotic associated biliary pseudolithiasis, you see. So the condition is nearly always reversible, you see, and the ciprofloxacin has to be discontinued, as I said earlier, and you have to go ahead for the other group of therapy and the supportive therapy. Then this may be associated with the parenteral nutrition, you see. So in order to avoid aging anticipated, you can use the mycolic acids, the cholic acids that can prevent the formation of gallstones or sludge formation. But remember the prolonged internal fasting is the risk factor for the developing of cholestasis. Why? As the internal feeding is very important, and that releases the J hormones, stimulation of the bile flow and gallbladder. But when prolonged fasting is there, you see what will happen. So this leads to the absence of these hormones, and the absence of these hormones, like J hormones, will not will promote, you see, the atony like situation, mean there will be no tone of the gallbladder, and consequently this will promote because this will promote the stone formation or the cholestasis, you see. And remember, your patient is already on parenteral nutrition, so they are at much more risk. Now, the pharmacological management of parenteral nutrition-associated cholestasis, you see, you have to give Ursodeoxycholic, you can use this drug, and you have to give metronidazole for the covering of anaerobic infection. In case of acute biliary infection, you see, what will you do? Remember, these are the common pathogens: Klebsiella, Enterobacteriaceae, family, and other related microorganism. And in acute cholecystitis, again the predominant is Klebsiella and E. coli, and some Enterobacteriaceae is there. But remember, bacteremia is common in acute cholangitis, very less common in with acute cholecystitis. So care shall be taken if the CBD is dilated and there is fever and infection is there. So your treatment shall be very aggressive, so that to combat the possible bacteremia and subsequent septicemia. So you should be quite vigilant in selection of the antibiotic as well. Remember, your antibiotic therapy in this case shall cover E. coli, which is gram-negative, bacilli, you see, and Klebsiella, and some Enterobacteriaceae as well. And you can combine, you say, for the anaerobe you can give metronidazole, and for the other you can give second, third generation cephalosporins, or you can give quinolones. Quinolones are the best drug. Ciprofloxacin, levofloxacin, moxifloxacin, you see, these are regarded as the best drug. In the case of the treatment of acute biliary infection, you see, you have to control the source as well, and you have to give supportive therapy. In case of supportive therapy, you have to take care of the fluid, and electrolyte supplementation shall be there. There shall be analgesics, there shall be antiemetics, as I referred to earlier, and you will go for the antispasmodic. So the other regimen is the physical maneuvers, you see, and these are decompress or drain the biliary duct system, you see, and this, in case of cholangitis, you will do the endoscopic retrogrowth cholangiopancreatopathy or percutaneous transhepatic biliary drainage, or as the case may be, endoscopic sphincterectomy, you see, and it has its own complications, especially when you remove a part of the sphincter of Oddi, you see, they have some problems and they cannot secrete, obstruction is there, and that is a separate story. So in case of acute symptomatic cholecystitis, you see, these maneuvers are also used. So beside drugs therapy, these are some surgical and procedural maneuvers are there, just to protect the support of these modern techniques and to relieve your patients. So treatment of acute biliary infection, in this particular case, as it continues since last few pages, the empirical antibiotic therapy should be there. Empirical means that antibiotics shall cover gram-positive, gram-negative, and Enterobacteriaceae, and this anaerobes, you see, and for that you have to give metronidazole and a combination of ciprofloxacin as well. That is regarded nowadays the best drug in antibiotic therapy. Treatment of acute biliary infection that as continues. So in case of empiric therapy, as I refer to ciprofloxacin, levofloxacin, cefepime, or third generation cephalosporin and piperacin tazobactam combination may be there, you see. But in case of MRSA, methicillin resistant enterococci, you can go ahead for the vancomycin. And yeah, and these classes of antibiotics, if they are combined meticulously, then it can be very helpful and life-saving. The empiric regimen for mild to moderate community-acquired acute cholecystitis, you see. Then monotherapy is usually there, and in severe cases, you can combine, you see, uh, uh, two classes of antibiotic as well. This is empiric treatment for biliary tract infection. There may be number one community-acquired acute cholecystitis, mild to moderate. So usually this class of antibiotics are there in community-acquired. You see acute cholecystitis with severe physiological disturbances or disadvantage. You will go ahead for this class of antibiotic. Remember, again, monotherapy is recommended. And in immunocompromised state, you see, you should be quite vigilant about the selection of antibiotic therapy. Why? Because your patient is prone to much more repeated risk of infection, you see. And in case of acute cholangitis associated with biliary enteric anastomosis, you see some surgical procedure or other. So then you have to go ahead for this ciprofloxacin, levofloxacin, gemifloxacin, or as the case is, plus metronidazole. The most important one, you see, healthcare associated biliary infection, the vancomycin may be added. Why? Because of the possible resistance strain of MRSA. So that because the therapy is usually empiric means that you cannot wait till the arrival of culture sensitivity report, because the culture sensitivity report, it takes at least 2 to 3 days, and you cannot wait for 2 to 3 days. So therefore, it's very important that your rational selection on the empiric basis of the antibiotic, that shall be very rational. You have to go ahead for the fluid and electrolyte supplementation, and you have to take care of the patient hydration, as there may be severe nausea and vomiting, and you see antiemetic drugs may be given, analgesics may be given. Remember, among the analgesics, narcotic analgesics will work as the conventional analgesics will not work. But amongst the narcotic analgesic, morphine is a drug that is going to produce spasm of the sphincter of Oddi. And if it is going to produce spasm of the sphincter of Oddi, you see, so then it increases the pressure of the bile, you see, and it can aggravate the situation. Therefore, when you are going to prescribe morphine, there shall be a muscle relaxant or atropine-like drug shall be there in the treatment of biliary colic. So better is to avoid morphine and go ahead for the other narcotic analgesics like meperidine, or you can go ahead for other class of drug as well. And this meperidine is an opioid analgesic, which is the drug of choice for the control of pain in the associated with cholecystitis. And the most important thing is it has inbuilt atropine-like effect, so there is no need to combine that, and therefore your patient will not be, a situation will not be aggravated. Preferably, it has to be given by subcutaneously or intravenous route, and if you are going to the intravenous, so that should be very slow. Intramuscular absorption is sometimes erratic, and that can create a problem for you. In case of supportive therapy, just to manage the pain, the combination of opioid analgesics plus acetaminophen may be there, and that can be helpful. You see, they may use the hydrocodone, oxycodone as narcotic analgesics, and acetaminophen as pain management, general pain management. Regarding antiemetics, to control the emesis, you see, you can take the support of promethazine because it has a very good sedation, and you can take the support of metoclopramide. It blocks the D2 receptor at the level of chemoreceptor trigger zone and central nervous system. But dystonia and extrapyramidal symptoms may be there, especially at large doses. Then regarding antispasmodic, you see, as we said, you will have to give this spasm relieving drug, and that is antispasmodic drug, as we discussed the opium and morphine, and you see, and codeine-like drugs. You see, piperine here is a very good drug. It is natural alkaloid from poppy at increasing the cyclic AMP concentration by inhibiting the phosphodiesterase enzyme, and thus it produces the relaxation, you see. But the most dangerous side effects is the polymorphic ventricular tachycardia or CDT points, especially in patients those who have a prehistory or congenital prolonged QT interval. So one should use that with caution. I hope now you understand the drugs that affect the biliary tract system, that constitute the antispasmodic, that constitutes it comprises an antispasmodic, anti-infective like antibiotics plus it is antimicroorganism therapy. You see that metronidazole and to cover the anaerobic infection, and you can give the the antiemetics, that is the to counteract to control the emesis, you see, and like metoclopramide and phenothiazines, and you can give them this analgesic drugs as well, and these analgesic drugs can be helpful. So all these constitute the drug therapy, and I hope we have covered both objectives. Thank you very much.